Now?
Yes.
Yes? Now yes. Okay.
بس ما موسى
Who,
ومفتاح.
who read information from our delivered lecture? I want to ask you some questions. Are you ready to answer me? Okay, now, who can answer me? So, can you tell me about the Webster's definition about health? Who want to answer me? Ali, Ahmad, Suleiman.
What is
Okay,
health?
I'll repeat the question, okay? Please tell me about
Okay.
Webster's definition about health.
Health is when a person does not suffer from any injury or any like
It's a definition about the health. Health is a physical and mental well-being, yeah, and freedom
yes.
from disease. He
Absence
defined,
of
yes,
absence of
Webster
illness.
defined the health like this. It's a physical and mental well-being and freedom for disease. It's clear for you?
Yes.
Yes, doctor. Yes.
My dear students, it's important to read this information and answer the questions because some questions from at your exam midterm quiz, it's from these chapters. Okay, so pay attention. So now, who can describe the core functions of public health? The core functions of public health. Who can describe? How many core functions we have? And
5 or 4?
three.
Three. Okay.
Yes. It's an assessment, policy development, and assurance. Do you remember this?
I read them last week, but I don't remember them very well.
I don't hear you clearly.
I read them last week after we finished our lecture, but I don't remember them very well. I should repeat them.
But you have my presentation, yes?
Yes, yes.
Yes. And pay attention at my presentation too. Okay?
Okay, doctor.
Who can tell me the current criteria used to define a public health problem? Current criteria used to define a public health problem. Okay. How many phases contains history of public health? And describe, please.
Doctor, I don't remember them very well. We should revise them before.
Now, 1 minute, please. How many phases contains history of public health? Describe them. Do you hear me, Ali?
Yes, yes, but we don't remember them very well. So I guess we need to.
Okay, okay. You after 7 lectures, you have midterm quiz.
Yeah, yeah,
You
I
must
know.
read this information and you must pay attention at my presentations because the questions will be from this book and from my presentations. And pay attention, okay?
Yes,
Please
doctor.
read it. Okay.
Okay.
Now, today I want to explain to you the global perspectives in oral health care. So, the perspectives are perspectives are dependent on many factors, including demographics, oral health needs, healthcare values and beliefs, and educational and healthcare systems of delivery. Each culture had its own way of meeting the oral health needs of its people. And one lecture can't cover it in detail, all of the nuances of oral care around the world. And the goal of this lecture is to provide an overview of healthcare providers and systems that will expose the student to other oral healthcare possibilities and encourage further study. After studying this lecture, students will be able to identify and discuss three influences on an oral healthcare system, discuss three barriers to access oral healthcare, and describe the role and education of oral healthcare workers around the world. By its own, the definition of the World Health Organization is the directing and coordinating authority for health within the United Nations system. It is responsible for providing leadership on global health matters, shaping the health research agenda, setting norms and standards, articulating evidence-based policy options, providing technical support to countries, and monitoring and assessing health trends. And in 2003, World Health Organization indicated that because of the high prevalence and incidence in all regions of the world, oral disease is a major public health problem. And today, our lecture describes factors influencing oral healthcare systems and examples of the various workforce provider groups involved in the care process in different countries. The way each country finances health care plays a role in the type of oral health care provided and how it is delivered. Financing can come from general government revenues, insurance, or direct payment by individuals receiving care. Most countries have a combination of financial support. When supported by government funds, treatment can be limited to specific types of treatment and specific treatments for specific population. For example, in Russia, mainstream patients pay for their own dentures. However, dentures may be funded by the government for vulnerable populations. Russia provides some dental care for all its citizens. A national document is published in Russia each year, which determines the services provided by government revenue and those funded by the patient. When a country like the United States uses a system predominantly funded by direct payment from the one receiving care, access to care is limited for those in a lower socioeconomic position. Population age, location, and oral health status have an influence on the design of an oral healthcare system. For instance, whether the country has more elderly or more children might determine the location of care. Elderly care might be more effective if provided in a nursing home, whereas many countries provide care for children in school clinics. If a large portion of the population lives in rural areas, it may be necessary to deliver care from mobile clinics or use alternative providers. If children in a particular country have a high caries rate and financial resources are limited, the focus of the system might necessarily be on restoring the teeth. Whereas if the caries rate was lower, the focus might be on prevention. Health policy of each country is formulated by politicians using data on oral health needs of their particular population. The policy reflects the health values and beliefs of the culture. Goals and objectives for actions are identified and are facilitated or restrained by available financial support. And oral healthcare providers and the educational systems vary in each country. For instance, the education of a dentist varies from a 2-year post-secondary training to 4-year post-university degree. And there are over 40 countries where dental hygienists practice and 50 countries where dental therapists practice. And dental assistants of dental nurses are employed in most countries. And their education varies from university education to on-the-job training. And the combination of all these influences on oral healthcare systems makes comparisons between oral health systems and outcomes in different countries difficult. However, with the blossoming of technology, it is becoming easier to share information and compare effectiveness of different systems. Barriers to oral health care can take many forms. The barriers may be structural, financial, and/or personal cultural. Structural barriers are related to the number, type, concentration, location, or organizational configuration of healthcare providers. Providers face barriers and economic challenges to developing practices in low-income areas. Many providers have large loan debts, and the cost of establishing a practice in low-income areas can be tremendous. Public programs and community health care facilities in the United States are seeing rapidly increasing caseloads as a result of the high cost of oral health care in the private practice sector and decreasing numbers of providers accepting Medicaid and a broader definition of dental indigence. Restrictive laws that prohibit the use of dental therapists and dental hygienists to provide services to special or rural populations and barriers to access to care for those populations. Financial barriers limit access because of a patient's inability to pay for a service or providers who choose not to provide care for those with limited finances. And as we described in last lecture, currently in the United States, the millions of Americans don't have dental insurance coverage, making access to care more difficult. And personal cultural barriers inhibit patients from seeking care or following provider recommendations based on personal or cultural beliefs. These beliefs include fear of providers of different cultural backgrounds and races, fear of the system, belief in their own healers, and culturally accepted attitudes and beliefs. Although there are many commonalities in oral health workforce in countries throughout the world, there is variation from country to country as to how each particular role performs, and the descriptions below are a general overview of each member of the oral healthcare workforce. About dentists. Most countries have dentists who assess, diagnose, and treat oral disease. As mentioned previously, the education of dentists varies between countries. In most countries, the length of formal education for a dentist is at least 4 to 5 years in a university setting, and dentists may own their own practice, work as an associate dentist, or work in community health centers and government agencies, depending on the oral health care system in the country. Dental therapists are also referred to as expanded duty auxiliaries and previously referred to in other countries as dental nurses and are employed in all 50 countries. In general, therapists are employed by the government and work on children in the school system. They assess, plan, and treat children of school age, providing preventive and restorative care and extractions where necessary. They work under general supervision of a dental officer who is available for consultation and may visit a couple of times per year to do chart audits and other quality assurance tasks. Dental hygienists exist in 37 countries, and the emphasis of service of a dental hygienist is to empower the patient to maintain health in the oral environment. The focus is on prevention, primarily of caries and periodontal disease. Dental hygienists assess a patient's oral health status as well as risk for disease, develop a plan of care, implement the plan, and evaluate the results of treatment. Although the focus of practice in most countries is similar, government regulations and other influences tend to be different. In Holland, dental hygienists can own their own dental hygiene practice, and many do. There are much of dental hygiene care is funded by the government. In Japan, dental hygienists provide more educational services and often provide assistance to dentists. The education of dental hygienists in the United States range from 2 to 4 years. However, the European Union has decreed that beginning in 2008, dental hygiene education will be at a bachelor degree level. Dental assistants are used in varying degrees in most industrialized countries. Their roles range from limited duties to highly sophisticated tasks. In general, they provide support services for the patient and the dentist. An example: would be cleaning up and setting up the room, sterilizing instruments, and greeting and seating the patient. The education varies from on-the-job training to some university education. About the dental lab technicians, they work in dental laboratories, fabricating appliances and restorations from instructions and materials prescribed by a dentist. And traditionally, they don't provide direct patient care. However, some technicians have taken additional training and are considered to be denturists. And denturists work directly with patients to create and feed dentures. You know that dentures is artificial teeth. Yeah? Other, yeah. So now we can describe some examples of oral healthcare systems in many countries. Now about the United States. The United States has primarily a fee-for-service or direct care financial model. This model works well for people who can afford dental services, as there are a wide variety of services available. However, the fee-for-service model leaves many low-income people without access to dental care. Pay attention. In the United States has a fee-for-service or direct care financial model. And low-income minority children continue to have high rates of oral disease and poorer oral health because access is generally restricted by low dentist participation in Medicaid programs and overall shortage of dentists to meet the needs of the population. Restrictive state laws prohibiting the use of non-dentist providers, lack of oral health insurance for patients, and lack of patient awareness and understanding of the importance of oral health. The dental nurse concept was experimented with within the United States in the early 1970s. For expanded function dental hygiene programs were developed in conjunction with dental hygiene educational programs. And this research demonstrated no significant difference in performance between the expanded functions of dental hygiene students and dental students. And several states also have expanded the services a dental hygienist may provide. Washington, Minnesota, Colorado, and Ohio allow hygienists to place restorations in teeth prepared by the dentist. In addition, the Indian Health Service in Alaska has developed an alternative model of oral health care delivery, and dental health therapists from remote villages have the education necessary to provide many of the combined services of a dental therapist and a dental hygienist. Initially, they have educated in New Zealand and University of Otago School of Dentistry. And currently, they are being educated in Alaska in partnership with the University of Washington. About Canada. Canada introduced the dental therapist program in 1972. Currently, there are approximately 300 practicing therapists, most of whom work in Saskatchewan alongside dentists, dental hygienists and assistants in the private sector providing fee-for-service care, and therapists who practice outside of this area are employed by government agencies and don't employed by government they are employed by government agencies and don't provide services for a fee. Therapists have been self-regulated for more than 30 years. So there are many dental hygienists practicing in Canada, and similar to the United States, each province and territory has its own regulations regarding the licensure and practice of the dental hygienist. And the majority of dental hygienists in Canada are self-regulated, which means appointed members of the dental hygiene profession establish the rules for the profession. In New Zealand was the first country to use non-dentist providers, specifically dental nurses, to help with the acute shortage of dentists and high oral disease rates. Oral health care for children in New Zealand is funded by the government and provided by dental therapists in school clinics. Adult dentistry is provided in a private dental practice model and paid for by the patient. Although children receive complete dental care, they may not develop an understanding of the value of oral health or the necessity of continuing dental visits after completing the school dental service. Because of this and the need for adult periodontal care, dental hygienists were introduced in 1989, and the first dental hygiene education program began in 1995 at Otago in Dunedin. The program was moved to the dental school at the University of Otago in 2001, and currently dental hygienists and dental therapists are educated together and receive a Bachelor of Oral Health degree. There are more than 250 dental hygienists practicing in New Zealand in 2008. About Australia. The Australian dental therapists can be employed through the government or in a private practice under the direction of a dentist. The dentist is solely responsible for the dental welfare of the patient. And after 2 years of education, a dental therapist can prepare teeth and place amalgam or composite materials, scale teeth, administer local anesthetic, provide oral health instructions, and take radiographs. There also are over 300 dental hygienists working in Australia, most of whom work in private practice in these cities. Only a few are employed in public health or in rural areas. Access to health care in rural and remote areas is greatly limited. Because of this, the Australian government has developed Aboriginal health workers, and also approximately 2% of the total Australian population is Aboriginal, and they comprise a high percentage of the rural population. Responsibilities of an Aboriginal health worker include screening and assessing managing healthcare equipment and facilities, and interpreting information to the patient. An oral health care component was added to the Aboriginal Health Worker in 1979 that focuses on preventive dental education and non-invasive emergency procedures to effect pain relief. Now about the Cambodia. There are also two types of private practice in the country. One type is the university-trained dentists, whereas the other is a traditionally trained dentist. Traditionally trained dentists have no formal education but are trained on the job by passing knowledge and skill from father to son. And traditional dentists are culturally acceptable and more affordable than university-trained dentists. More than 80% of the Cambodian population lives in rural areas and doesn't have access to oral health care. A national survey in 1991 demonstrated high rates of dental caries and periodontal disease. Dentists were reluctant to work in these rural areas due to the lack of facilities and equipment. Working with the Ministry of Health and Institute by World Concern, the dental therapist program was developed in 1992, and the program offers a certificate which requires 6 months of training and a diploma for 1 year of training. On completion of the educational program, the dental nurses are given a set of instruments and the materials needed to provide basic preventive and curative needs, which include oral health education, local anesthetic, scaling, and extraction of teeth. They also perform the atraumatic restorative technique, which is also referred to in the United States an interim therapeutic restoration. This provides the population with basic care at a cost the country can afford. About Russia. The government in Russia provides some dental care for all its citizens. Each citizen is assigned a specific clinic. If they visit their assigned clinic, medical care and some dental care are free. Each year, a document is prepared by the government to clarify what services are provided. There are also private dental practices in the larger cities. This state-of-the-art practices cater to dignitaries and an elite population. There is demand for aesthetic dental services. Meanwhile, dental decay in secondary school children has increased from 60% to 19%. In response to this increase, the government began training dental hygienists in 2001. To date, there have been 1,000 hygienists educated, and the government oral health service is not set up to employ hygienists. So they either work in private practice or as dental assistants in the government clinics. In the past, stomatologists were trained to perform services much like dental therapists. It was not successful and has been discontinued. About Poland. Dental care in Poland is financed through public and national service. There are also well-appointed private clinics. Dental care is provided by dentists and dental hygienists who are supported by dental assistants and dental technicians. Training for dental hygienists began in 1983 and the Polish Dental Hygienists Association was established in 1997. The education of dental hygienists continues to develop as the European Union required entry-level dental hygiene to be a bachelor degree by 2008. According to the chair of pediatric dentistry at the Warsaw Medical Academy, more dental hygienists are needed as 19% of children 6 years and under have dental caries. Overall, studies report the cost for providing dental services by a non-dentist provider as lower than that provided by a dentist. Studies also indicate that more quality services could be provided at lower cost. This cost-benefit trend has been noted in the medical profession with the introduction of mid-level providers. And it was also reported that nurse practitioners could effectively provide between 75% and 80% of adult primary care services and up to 19% of pediatric care services. Therefore, these professionals can provide quality care to more people at a lower cost. If the cost to train a non-dentist provider who can provide definitive treatment takes one-half of the time and resources necessary to train a dentist, it can be anticipated that the cost to deliver care will be lower. And concluding that non-dentist providers could increase the dentist capacity to provide quality treatment for more people at the lowest possible cost. Broader investigated studies related to the New Zealand dental nurse and found the annual cost per patient was 50% less than care provided by a general dentist. Success in other countries and research in the United States clearly demonstrates that non-dentist provider can be taught to provide basic restorative and emergency care. The use of non-dentist providers to perform services traditionally done by the dentist can in fact provide greater quantity of services with equal or higher quality at a lesser cost than has heretofore been provided. And the time and cost factor to train and produce this non-dentist provider amounts to a small fraction of that required to train the traditional dentist. The application of this method can be a primary factor in meeting the needs of the public, satisfying the ideal philosophy of the profession. And global prevention efforts, it includes in addition to different models of care delivery, numerous countries have developed prevention and health promotion measures to reduce oral disease rates. These initiatives include community water fluoridation, fluoride supplements, fluoridated milk and salt, fluoride varnish, and xylitol gum. These different health promotion efforts will be described in the next lectures. The oral health disparities across regions and countries present a dynamic challenge in addressing oral disease. The World Health Organization has developed worldwide priority action areas for oral health. The first action area is centered on the use of fluorides. Not only should community water fluoridation be promoted worldwide where applicable, but also other modes of fluoride therapy, including toothpaste, milk fluoridation, and salt fluoridation. The second action area is associated with diet, nutrition, and oral health. Many oral diseases are affected by changing lifestyles related to diet and nutrition. This is an opportunity to partner with other programs to address common risk factors for disease. Preventing tobacco use and tobacco use cessation is a third action area. This also is an opportunity for integrating with other health promoting programs. World Health Organization has targeted both ends of the age spectrum. It has launched programs in schools and with youth populations to control oral health risks for young people. In addition, this targets education and So, Basil, do you hear me?
Yes, doctor.
Yes. I want to ask you one simple question. Can you answer me?
Maybe. Who
Maybe.
knows?
Okay. Can you tell me uh, two main global entities in public health? It's very simple question.
I don't know.
You don't know
No.
why? Because you didn't read the chapter one.
Yes, exactly.
Yes. Okay. It's a World Health Organization and Pan American Health Organization. Remember this.
Mm-hmm.
And can you describe the World Health Organization abbreviation? Do you know the abbreviation World Health Organization?
No, I didn't read anything from the book.
Um, you joined now or
Yeah.
okay?
Is it
Please,
WHO?
Suleiman, you know
Yeah, the abbreviation for World Health Organization isn't it WHO?
WHO? Yes. And can you tell me, Suleiman,
Yes.
where are located headquarters of World Health Organization and Pan American Health Organization?
The World Health Organization. I did this the other day.
Yeah, it's located in Geneva,
Geneva.
Switzerland.
Oh, that's it. No, I was thinking Switzerland. Oh, that's it. And the Pan American one isn't that in Washington?
In Washington, yes. And
What?
it contains also 35 countries.
Yeah.
Remember this, okay?
Okay.
Can you tell me what is the dental public health?
Like as a like a general thing.
What is the dental public health?
Doesn't it deals with the prevention of like oral diseases and promotion of oral health?
Yes, well done. Goodbye. Okay. Maybe you know some questions.
I'll be honest. Lecture one, I did. I need to go over your lecture two properly.
You read this chapter one, yeah?
Yeah, majority of it.
You are in Georgia now.
No. I'm still in the UK.
Now you are in UK. Okay, everything is clear, yes, from my presentation and when I'm explaining you some lecture, everything is clear or not?
Yeah. No, because I'm reading.
It's,
As you're reading, I'm reading the chapter as well. So
yes, after the reading the chapters and pay attention at my presentation, I think that everything will be clear for you.
of course, can I ask one question, please?
Yes, I'm listening you attentively.
Do you know how you said in regards to the exam will be pretty much from the book? So would you recommend to majority of the time read from the book from the chapters you have told us to read from?
No, read from the chapters and pay attention at my presentation. And at the end, maybe after five lecture, I want to help you and I want to send you some questions with answers, with
Uh,
right answers. And pay attention at these questions also and the questions at midterm quiz. It will be from this book from my presentation and from these questions. So
okay.
don't worry about it.
Thank you.
Okay? Okay. See you soon in the next week. Okay.
Okay. See you next week.
Okay.
Bye bye.
Bye. Bye.